And Elena, whenever you're ready.
Very well. Good morning, everyone. And I'm delighted to be here another year with you all. I'm going to tell you, as always, a little update on Wiedemann Syndrome with the latest news, the latest publications about what's being discussed. Well, to do it, what I've been looking at this year has been several articles that have come out in recent months that I thought could be practical. Thank you, Mrs. Perez. In a little while, in a few months or whenever, may the renewal of the 2018 international consensus influence the content of this consensus and change a few things. So, well, do you remember the consensus is a very, very complete guide that talks about the clinic, the diagnosis, the oral read, the general handling of the handheld BW, and, well, in general, the participants in this consensus were mostly in agreement about everything, but there were some topics that were debated, such as in the right your moral. Do you remember that I said that all genetic variants should be regularly ultrasound except those of IC2, who are the ones who have the risk of your lowest morals? However, there are people who say, well, maybe here we should maybe screen everyone, or maybe the hepatoblastoma screening that we have removed from the guide needs to be reinserted. Well, these are the topics that are a bit controversial and are being discussed quite a bit lately. And as genetics is one of the main topics, I always like to start presentations by talking a bit about genetics, doing with a brief review of the variations of this problem. Well, here we have chromosome 11, specifically region 11p15.5, which is where the genes involved in man's BW are located. And we have the mother's copy and the father's copy. In this region, there are genes that encode the proteins involved in cell growth. There are some that slow down growth, like, for example, H19 and CDKN1C, and there are others which accelerate growth, which stimulate it, like IGF2. There is usually a balance between these proteins, so growth is normal. If there is any alteration, well, if growth stimulating ones predominate, like IGF2, there is more growth, as happens in BBB and so on. And if the opposite happens, if the ones that dominate are the ones that slow it down, there is limited growth, as in the case of Wiedemann's mirror syndrome, which is Silver-Russell. So these genes are subject to something called imprinting. This is imprinting. Well, usually in chromosomes, we have two copies, one from the father and one from the mother, and both work. Same, the mother's genes express and the father's genes express, but in those subjected to imprinting, this does not happen. Only one of the copies works, or the father's or the mother's. To regulate this, there are different mechanisms, and one of the most known is methylations. Do you remember that sometimes we would see them as like the drawing of a lock, a switch, or not? So if there are methylations, we put a lock, and the gene doesn't work. If we remove them, the gene works. This is what happens in this region. For example, we see here, in the mother's copy, we have some little circles that are not filled. If they're not filled, it means there is no methylation. There is no padlock. If they are filled and are black, it means there is a padlock. In the mother's copy, where there are no locks, no methylations, this makes H19 work. It slows growth. In the father's copy, there are methylations, there are locks. H19 doesn't work, but HF2 can. It accelerates growth. Balance between the break and among the stimulus. Well, this is about the IC1 region, okay? If we go to the IC2 region, we have mother's copy, some padlocks. Here, certain proteins are inhibited, others are stimulated, and it makes the CDKN1C that slows down growth. It works well. However, in the father's copy, there are no locks, and CDKM does not work.
I don't know.
That too.
Balance.
One yes and another no. All right. If there are issues with these vents, with these locks, problems arise. So now we move on to the next one. And here we see the main alterations of the Wiedemann. Let's start with the hypermethylation of the IC1 region. Here at IC1, remember that we had locks on the father's copy, but we didn't have them on the mother's. But when there's hypermethylation, new locks appear on Aramadri's copy. In this case then, the H19, the brake doesn't work, neither in the mother nor in the father, and the IGF2, the stimulus, works both in the mother's copy and in the father's. Father, excessive growth, alteration. This alteration occurs in 5 to 10% of cases, as you know. Then we go to the second one, the hypomethylation of the IC2 region. Here, if there is hypomethylation, it means there are fewer locks. In these cases, the locks we had on the mother's copy are gone. They're not there. We don't have ventilation on this one or this one. And CDK doesn't work in 1C, neither in one nor in the other. Therefore, there is little growth restraint. And proteins that stimulate it predominate. This alteration occurs in 50 to 60% of the cases. In the next slide, we are going to see another type of genetic alteration of Wiedemann. Can you pass, Pablo, please? Thank you. That's paternal uniparental disomy. In this case, there's no problem with the ventilations. What happens is that instead of having one copy from the father and one from the mother, we have two from the father. Father and father, therefore choose F2. The one that was formed in the father's copy is formed twice, so we have double IGF2. So there is more growth. This happens in 20% of BMW cases. And in the other group, in the fourth, we have alterations of the CDK1C protein, meaning there are no alterations in methylation. There are mutations in the protein, then it doesn't work. There is little break, and proteins that stimulate growth prevail. And this happens in 5%. These are the four main groups: hypomethylation, hypermethylation, uniparental disomy, and mutations in the CDK1C. Then there's another type of alterations like duplications of electrons, which are less frequent. Out of all these mutations, they are not inherited, but appear sporadically, except in some cases of mutations in the CDK1C, which can be inherited. Alterations have even been described in families over several generations, even in 4 consecutive generations. Well, now these alterations, I'm going to focus a bit on this one, on paternal uniparental disomy, because several articles have recently appeared discussing it. So let's move on to the next one. And here we have disunion and parental, 2 copies of the father, one and the other. Excess of IGF2 increases growth. How does this happen? Let's look at a drawing, a schematic that explains it a bit better in the next slide. Here we have a pair of paternal chromosomes and a pair of maternal chromosomes. So under normal conditions, when this couple has offspring, usually children are going to inherit 1 copy from the father and 1 copy from the mother. For instance, here, in this case, we see that he has inherited the smooth blue from the father and the blue and white of the mother. Normal. Here we give the plain pink with the green and white. The smooth blue with the green and white, and the fuchsia, the pink, with the blue and white. Okay, these would be the 4 normal possibilities. But in these cases, there is disomy. In this case, for example, we inherit the 2 copies from the father, uniparental disomy. In this case, we inherit a copy from the father, but it duplicates. So it would be the same 2 copies from the father. In this first case, it would be called heterodisomy. And in this last one, it would be isodisomy. But the same, both are from the father. And in these cases, both would be from the mother, or one and another, or one and another, each. Goodbye. Well, this is what happens in paternal uniparental disomy in Benku and others. What is the clinical picture that we already know about this disorder? Okay, the next one, we see that if we compare it with other types of genetic alteration of Wiedemann, in this alteration, there is less frequency of macroglossia, and there are phalluses, but however, there is more lateralized hypergrowth and a higher risk of tumors than with other alterations. There would be a 16% tumor risk. All right. Well, now. Yes, come in, Pablo. Thanks. What happens if this alteration, that in the BWID, we keep 2 copies of the father in that region at 11:15? What happens if instead of being only in this region, it's in a broader region of the chromosome, or if it's in the entire chromosome? Okay, because so far we only talked about the disomy in that little piece of the chromosome. But if it's larger, well, if there is no chromosome entero, what happens? Well, this is what is called mosaic genome-wide uniparental disomy, which is being talked about now. So in this case, a person would have normal cells that had one copy from the father and one from the mother, and another group of cells with disomy. There would be a mosaic, some normal and some with disomy, but a big disomy of the whole chromosome. It has been seen that there are cases like this. There are about 30 cases published. The first one was seen in 1995. That of the uniparental disomies of the UAB, so there are described between 2 and 16% of them. They could have this alteration, the disomy could be wider. What happens is that it is not known, because when this alteration is searched, only that region is searched, and the probe that is going to join with that region of the chromosome only looks for that little piece. So maybe the percentage is underestimated. All right, let's move on to the next one. What symptoms might these people with this mutation have? They might have the typical Wiedemann clinic, but it might overlap with symptoms of other mutations, like Kagami-Ogata syndrome, for example, that has disomy on chromosome 14, or Angerman syndrome, that can have disomy on 15, or neonatal diabetes and low weight, disomy on chromosome 6. They could have more risk of tumors, and maybe the age at which they can appear is slightly extended. It could seem more risky also in adults, but well, all this could be because, of course, few cases are known and there are few studies. So in these articles, what they recommend is to achieve more studies, especially in adults, and if at any point the guide is updated, consider saying, well, we need to do this test, but in wider chromosome regions to search for this so wide dysphoria. Perhaps the tumor screening protocol also needs to be modified to include these alterations because the risk may be higher. Well, this is a topic that remains up in the air and perhaps is increasingly discussed. Right, then in the next, I'm going to speak of another alteration, the northern CDK. Several articles have also come out. Lately, they focus on this alteration. I chose this one because it was published. It was made in Spain, and in which they described 21 cases of people with CDKN1 alterations. There are other interesting articles as well, but where I put this one, there's one from the group of Americans from Cali, in which they describe what I was saying before, CDK1C alterations in 4 consecutive generations, and they describe a bit the clinic, as in this case. And they see there is a significant percentage. In this case, 100% of patients have macroglosia. There is also a fallow cell, as in other groups. Alterations in the auditory papillons, transient neonatal hypoglycemia. Perhaps compared to other groups, what stands out is that in the CDK1C, there is less lateralized hypergrowth. Here, for example, in uniparental disomy, there might be a higher risk of genitourinary alterations. There's also some cases of polydactyly.
And also, well,
I still don't know. In case of capillary malformations, the medial duct already cases of general prematurity similar, except some difference to other genetic alterations. As for the tumors, in this article, they saw a ganglioneuroma had appeared. We move on to the next. The previous one.
Thank you. Goodbye.
Thank you. And in other similar articles that talk about CDK1C, they had also seen that there is more risk of neuroblastoma compared to another group. And generally, tumors derived from the neural crest. Is the risk low? Yes, but it's there. And the screening in the protocol doesn't include looking for these tumors. So perhaps these tumors could be searched for screening for catecholamines in urine up to 4 years. Well, it's another doubt they leave in there for future consideration. Okay, then in the next, let's go. I'm going to talk about another article. I like this one because it's a very broad article with 831 people with the specter of Beckwith Wiedemann, which is Peter said, where they take the International Council and specifically The diagnostic score sets major and minor criteria to assess each patient's score. And they say, well, let's see if this works. If it is useful for the diagnosis, if it is related to genetics with the clinic, let's see. So in the next, we see what I was telling you, the score that raises the diagnosis. So we have a cardinal clinic. It gives you 2 points for each characteristic. I mean, if you have macroglossia, it gives you 2 points. If you have ophalos, it gives you 2 points. Lateralized growth, Wilms tumor or nephroblastoma, the multifocal bilateral tomastosis. Hyperinsulinism in the early days that needs treatment, and alterations in pathological anatomy. 2 points would be given for each of that. Subjective or minor criteria, which would be a birth weight above 2 standard deviations, the facial nevus, polyhydramnios, changes in the auricles, and transient population, but less than a week, and tumors, nephromegaly or hepatomegaly, and abdominal alterations, such as umbilical hernia or diastasis recti. That would be a point. You already know that above or equal or greater than 4 points. We already have a clinical diagnosis of from Beckwith Wiedemann. We wouldn't need to be so careful. Also, the genetic study, to say it's a case of Wiedemann, although you always know that genetic study is recommended to know the alteration and also to know a little about the clinical aspect. So in this article, they evaluate the usefulness of the scoring. And what conclusions did they reach? We move on to the next. Well, they found this was very effective for diagnosis. All the patients, they analyzed it, they met the requirements well and fit into the characteristics. Regarding the genetic groups, they saw that there were no differences. There was no group that had a higher score than others, maybe. At least one had more major criteria, but they are going to compare. There weren't many differences. There weren't many differences in terms of the tumors, that is. Just because they had a higher score doesn't mean they had a higher risk of developing tumors. This is important. They also saw that when the score was lower, there were more slips of paper indicating that the genetic study was negative, that they didn't find any changes. So it doesn't mean she didn't have it, but rather they didn't find it. Perhaps this is due to some mosaic. They might have studied some tissues that have no alteration, but if they study, for example, the tissue of a hepatomegaly or the tissue of a perfectly fine arm, there are more chances of finding alteration. That's why they recommend that if the scoring is low, to do genetic studies in tissues other than blood, which is what is usually done. Then they also found out that the chances of having a Beckwith Wiedemann, if an assisted reproduction technique was used, were greater. Therefore, perhaps in the future, in the SCORAX, it could be inserted. Use these techniques as a minor criterion to increase their efficiency. Well, that's generally what they arrived at. It seems quite interesting because this study is very broad. All right, then let's check the next one. And here comes the novelty. This one is hot off the press. It caught me a bit at the limit. It came out the other day. I saw it on Thursday. And it's a study in adults. It's an international study that the Americans, the Cadiz group, have participated in. The Italians have participated here. The group of Pablo Lapuncina. So it is a study where they've grouped 2 sets of patients, adults. The first is a group of American people, 55 adults, between 18 and 59 years old. And the second is a group of Spaniards, 49 adults, between 18 and 47 years old. The thing is, the groups are very different because how did they do the study? They passed out a survey to the American, and they were asked about what clinic you had as a child. What disorders did you have? What was your genetic disorder? What specialist consultation did you go to? What were you operated on for? What complications have you had with the surgeries? Then, when you are older, how are you? What problems do you have? What worries you? Are you happy with the doctors? Well, lots of open questions, and they've been answering. However, in the group of the Spaniards, these are not open questions. They have taken data from the registry they have of these patients, from the registry they have, from the data when they were children, and from what they have now when they were adults. They are very different, and it's hard to compare them, but, well, they can reach interesting conclusions. So on the next slide, we see a picture where it will compare the clinic from childhood within the American group, from childhood within the Spanish group, and from adults in both the American and Spanish groups. So here we see the differences between some and others. For example, in the genetic alterations, here in the Spanish group, we see the distribution of IC1, IC2 disomy. This is more or less what we know so far. The most common is EIC2 hypomethylation. They had 30 out of 45. Well, actually, there are 49, but 4 of them had unknown genetic alteration. So, well, 30 out of 45 had IC2, hypomethylation of IC2. 6 out of 45 had disomies. 3 out of 45 decays into 1 CD, 2 out of 45 hypermethylation, and 4 other alterations. Okay, roughly the distribution we know. However, we see the group of Americans, and wow, out of the 55, only 13 did they know about the genetic study, because they were the ones who had filled it out. So there were many who did not know what their alteration was. Although if they knew it at the time, they didn't remember or couldn't define it very well. So this makes them think that maybe we are not informing them well what alteration they have, with how important that is to know for later follow-up. So, well, here we see the difference between one and the other. Then regarding the clinic, especially for children, there isn't much difference between the two groups, since we value open-ended questions and the register, roughly more or less. Macroglossia is the most common, more or less coincides, about 80 and something % between the two groups. Hypertrophy might be a bit higher in the American group. In the omphalocele, more or less the same in one group or another. A hypoglycemia too, I refer a bit more in the group of Americans than in the one of Spaniards. Well, even if there is some difference, roughly the same. But then we see the adults, and we see a lot of difference. We see, for example, macroglossia. In the Spanish group, only 3 out of 49 adults are recorded. And we go to the Americans, and 56% report having adult macroglossia, that there is a lot of difference. Also in hemihypertrophy, 43% say they have adult hypertrophy, and very few in the adult group. There is little record. And the same thing happens with other features. There is still little record in adult patients in Spain. Regarding the tumors, here we see in the United States, in childhood, it's not reflected in the table, but they mention it in the article. They say there were 2 Wilms tumors, 2 patients with Wilms tumors, a hepatoblastoma and an osteochondroma. And in adults, 1 patient said she had a benign breast tumor, another kidney one, and then uterine carcinoma, and another thyroid. Another adult had a pancreatic tumor, another thyroid tumor, and a patient had multiple fibroadenomas. In the group of Spaniards, they only say, they don't detail, that the incidence was similar in childhood. And it says nothing about the adult group, maybe because we still don't have a record. In the following, we see a table with adult characteristics. Here, the adults were saying what was happening to them and what worried them. Above all, we see the highest percentages.
They suggest
They had mouth
stay
problems
longer.
with their teeth, especially related to the source from macroglossia. They were also worried about kidney alterations.
Okay.
Many had cysts in their kidneys in the back, nephrolithiasis, and also problems in the gastrointestinal tract. Also problems in the genitourinary system. Here above all, they highlighted infertility problems and musculoskeletal problems, mainly related to hypergrowth. Scoliosis, back pain, contractures, these will be the main characteristics, what they were mostly worried about. And then, well, the Spanish group, well, there is little data, mainly genitourinary alterations, some alterations in the kidneys, but little recording of inclusion with what we have in the American group. Okay, and in the next, here I describe a bit in the open questions from the American group. They ask psychologically, how are you? What problems have you had? What worries you? So most of them say that they felt different in their childhood and some had suffered discrimination or bullying at school when they were little. Most had overcome it and some still had after effects as adults. Also, they agreed quite a bit that they were somewhat satisfied, especially in adulthood, with the medical care, because they reported that doctors often had a lack of knowledge about the disease. And then another thing that worried them a lot is the fear of passing on the alteration to their offspring. I mean, they needed more information about the risk of genetic transmission.
Well, this is kind of the study.
I study, which is fine, but I believe it's just the beginning. We are going to release a bit of information, but we still have a lot to do. Somewhat the beginning to publish other more complete articles with more information soon. And well, to conclude, I was going to post this article, which is mine, the one that was published in December of 2022, where I updated the primary protocol. I took the opportunity that we had been at the Congress in Italy in June to talk a bit about the importance of family associations and rare diseases. I wanted to highlight a bit the collaboration between the different European associations. In the case of Wiedemann, along with the collaboration of doctors from different specialties to promote research and knowledge of these rare diseases, specifically BWDMA. And at the end of the article, I put the primary protocol, which is a bit updated. In the following, we see the table, which is more or less similar to the last one. Furthermore, at the last review, but well, I've added some things. For example, I've added the ENT in interconsultations. In children, important for rule out sleep apnea syndrome, recurring otitis, and any hearing problems adults may have. I've joined 2 columns. Before I had one of fragments and there's another one of cardiac evaluation. Now I've combined them in other tests for evaluation. So it's recommended to do an EKG, a cardiac evaluation in certain genetic alterations, certain IC2 alterations that can be associated with a long QT syndrome. And I've also suggested that sometimes a dysaucia can be evaluated if we want to make a size forecast. And above all, I put that in. In the topic of adults, I set up some consultations that it would be good to attend, especially nephrogenetics. And I have also highlighted in educational and psychological support that I always put on the table that had to be valued in each query. But now in each age, I put that it's important to also assess the parent's adaptation. And well, that's been all the update for this year. I hope you liked it and didn't get too bored.